Okay, we turn now to another area where the board does really constantly seek assurance, and that's implementation of the new model for emergency preparedness, resilience and response. Ian.
Thank you, Chairman. Board members are well aware that it's essential that the NHS is able to be both prepared for and then to deal with any threats to its operation 365 days a year, so that we're always here for patients. And the work on emergency preparedness, resilience and response is basically around ensuring that that capacity is in place, and that in particular the role of the Commissioning Board is sufficiently established such that we are ready to take all appropriate measures to deal with any threats to the operation of the NHS from the 1st of April. And moreover, that we have established across the country through 36 local health resilience partnerships the arrangements for bringing the agencies together, public health, the NHS, local authorities and other key stakeholders, to make sure that the NHS is properly prepared, exercised and ready to deal with whatever comes along. You will recall, therefore, discussions we've held most recently in November, and the purpose of this is to give an update and further assurance on, I think, the very significant progress that has been made up and down the country in the intervening period as we now look ahead to the 1st of April. In the interest of time, I'll just pick out some of the key highlights because I'm sure members will have read the paper. I think it's first worth mentioning that we built the requirements for emergency preparedness into Everyone Counts, so that the guidance to the NHS on what needs to be done in terms of its operations next year are absolutely having this hardwired into it. We have launched a comprehensive set of the key documents that are there for the NHS, developed with the NHS, so that people know what they need to do, and some examples of that. We've published a command and control framework for dealing with significant incidents and emergencies, guidance on business continuity, and a set of core standards for emergency preparedness, resilience and response for the NHS. Above and beyond that, we have been going through a major exercise to recruit and equip our own staff to deal with the issues around EPRR at every level, from area to national, and so there have been major moves forward in terms of recruitment of staff at both area and regional level. There's been extensive training of people who will be on-call directors to be able to be prepared for the duties that they will have to discharge, and a set of training courses around the core skills of strategic leadership in a crisis have been undertaken across the country, and the rotas that will be necessary such that we have 24/7 capability are well being put into place across the country, and we're on track to have those in place with trained people right across the country by the 31st of March and ready to go. So I think that is positive. I think in addition to that, we have seen excellent progress in each of the areas. So we have now established 36 local health resilience partnerships. That's the full number across England. At the time of writing the paper, I think 35 had met and formed. Subsequent to that, the map is now complete. So I think that is significant progress, because those are the multi-agency fora that will drive the resilience agenda going forward. In terms then of the assurance that the board, I think, quite reasonably looks for in this, over and above the description of the activities, I set out in November the processes of assurance that we would be going through to collate the level of confidence that we need. So you will recall that there are a series of command post exercises. Those have now taken place. I think they have been regionally based exercises which have tested the system and the new players in it, and have been a very valuable source of learning. It has, I think, generally confirmed the system, but has also raised issues, particularly around communications, which we are now resolving, which I think have been helpful. We're engaging in a process of inter-regional coordinated impartial assessments of readiness to ensure that we have some evidence, and initial signs are that that is going well. The aim being that that information is collated and compared with the process of declaration statements of readiness that we are requiring from each of the 4 regions as per our discussion in November, and we'll have that material by the 15th of March. So the summation of all that information, the exercises, the impartial assessments, and then the statements of readiness come together such that we will be aware and able to demonstrate our readiness by the 31st of March, such that we can assure this board, but also equally our stakeholders, including the Department of Health, who have obviously an interest and who will give their own broader assurance to cross-government on our preparedness. So I think in terms of the risks, some of which were described in the paper, we have made significant progress. The recruitment risk, which was the most significant risk in November, is largely mitigated now. We've made excellent progress on that. We have got communication out to the service. We have got communication out to CCGs. We have identified through the command post exercises and the impartial assessments that have already taken place a need for further communications support and a strengthening of the communications rotas. And as a result of the budget setting process within the board, we have identified the resource to do that. And so that is now going into place. We're working up that model. That will be in place for the 1st of April. So overall, I think I would summarise saying that this has been an immense programme of work, largely invisible, I guess, to many people because it tends to be just within the communities of management across the country, but it has been an immense process to move to completely new arrangements across the country. The progress has been very significant since we met in November, and my judgment is that we are on track to go live from the 1st of April as per the milestones that we've discussed before. I think that would be my summary. I'm very happy to answer any questions that colleagues might have, Chairman.
Well, thank you, Ian. I think when this first came to us, there was distinct nervousness around the table, that this was one of those things, if it were to go wrong, its impact would be quite extraordinary. So I can say I'm very reassured by what we heard in November and what we've heard again today. And as always, this is one of those areas of activity where the work takes place behind the scenes, and the surest sign of its success is that we never see it. So let me invite comments from colleagues on the table. Ed Smith.
Yeah, no, I think it's obviously been a challenging and good piece of work. I guess my question, Ian, is as it all comes to a conclusion, are you expecting to give us a paper which formally indicates all the levels of assurance that you have obtained, such that you as an executive can sign off formally to us? Or are you looking at some stage to have somebody come in and independently look at the assurance processes that you have gone through? Because I think it is such an important area. The board needs a formal sign-off on those assurance processes, and I just wonder what that mechanism is.
Shall I respond to that? So we obviously haven't got a board meeting in March, which is a slightly confounding factor, because that would be normally the place at which the process of the summation of that material, which we will be doing for the 31st of March, would be brought together, probably with a recommendation from me as the designated lead director on the board, which I think is the appropriate form of governance around this as we look to move into the new arrangements. That does sit alongside, I think, the the assurances that the government will seek and that our partners will seek at a local level. But I see my role as, if you like, the formally designated director sitting around this table to be forming that judgment and advising you. I think perhaps, Chairman, I'd like to take offline the format, given that we haven't got a meeting in March, that we might use to provide that level of assurance, and perhaps I could pick it up with Ed on behalf of the Audit Committee offline.
Thank you. I'd be grateful if you do that. Thank you. Subject to that, are we happy to receive the report and note the progress? And Ian, thank you for the progress and for the reassurance you've been able to give us today. Right, we move on now to the agenda item number 7, which is the Commissioning Board Governance Review from 1st of April. And Bill, this is your paper.
It is. Thank you, Malcolm. This note brings the board up to date on the refresh of our governance arrangements, which we've discussed previously, to make sure that our decision making from the 1st of April properly reflects the new functions and responsibilities we'll be taking on. The aims of the work are to make sure that there can be a patient focus at the centre of all the ways we make decisions, that there's transparency in our decision making, and therefore that we can properly be held to account by Parliament, patients and the public for what we do. The paper summarises 4 areas of governance we've been looking at. The first is the scheme of delegation, and Margaret, who can't be here today, and Ed have been very helpful in their input to this piece. The principles we're now settled on for the scheme of delegation is that the board or committees of the board should be establishing frameworks within which decisions are made, so there's transparency, openness and proper parameters around those, and then that we should be delegating as close to the operational frontline as we can, the actual decisions consistent with the function we're talking about. So that's the broad frame that we've worked up and which has been developed with some very good input from a number of our area directors from Ian's directorate. The really important piece that we're now completing over the next week or so is to get the list, if you like, of day one sort of operational decisions absolutely clear, so that we can have the schedule of those which will empower our area teams to respond to any problems if they arise very early on. So that's the safety and security I think the board would want. And we're asking for delegated authority from the board for yourself and the Chief Executive, and I know a number of the other non-executives would be very happy to be part of this, to agree the final scheme and the schedule of decisions delegated. The second part of the paper, and Bruce may want to offer some comments during the discussion, is a recommendation to set up a clinical quality risk committee. We think this is very important for 2 reasons. First of all, it places in a very transparent and clear way matters of clinical quality right at the heart of the board. And secondly, it allows us to make sure that we've got the right sort of expertise drawn from the very best of clinical advice in the country to be sat there advising the board on how best we can discharge that risk. And that's something we've discussed on a couple of occasions with the audit committee. Ed may wish to make a comment, and I think is strongly supported as a good proposal by the audit committee. Thirdly, we're just asking the board to note the progress we're making on policies. There's a whole set of policies we need to have in the right place, and finally there are the proposed delegated financial limits, which again have been through the audit committee, that come here for the board's approval, and again I'm sure Paul or Ed would be happy to talk to those. One specific Chairman, I'd like to raise around delegated authorities. When I talk about those early decisions which will need to be made, some of the earliest now will be around the specialised commissioning contract sign-off. So we would like to record a delegation of that authority as yourself and the Chief Executive, who may well discharge it through the Operations Directorate.
Thank you very much. Ed?
Yes, I mean, as a board member, I can firstly say I'm absolutely delighted about the establishment of a quality and clinical risk committee, because I think it provides absolutely the focus on that range of activities. But as chair of the audit committee, I'm even more delighted because I think it separates out a job which is very, very focused, and then we need to look as an audit committee how we interface with that clinical risk committee to provide overall assurance to the board on all the matters we're responsible for. So I'm delighted. I think it's an urgent priority that we establish it and that we then work through the respective governance of the two subcommittees.
Thank you.
Good. I think, Bruce, did you want to add anything on clinical quality?
I might just say a little bit on the Clinical Quality and Risk Committee. I think it's an absolutely appropriate thing to do. Patients understand the risk of their disease. They understand the risk of treatment. They make value judgments based on that. What they should not have to even think about is that the way we organize our services, or the way we address those services, or the way we commission them adds to that risk in any way. So I think the development of this committee provides us with two opportunities in my mind. The first is one that was addressed by Robert Francis, which is to understand the very powerful role I think we have as commissioners in not only ensuring that we purchase the very best quality of care from the best organizations that we can, but that we understand where there are emerging organizational risks in the system. And to help us do that provides us the second opportunity, which is to bring in powerful external clinical advice into that discussion through Royal Colleges, specialist associations, and others. People who at times, I think, over the last decade have felt themselves relegated to the position of commentators. I'd like to see them as participants and players in improving the quality of the care we offer the citizens of this country.
Thank you very much. Bill, we endorse the paper. Could I just, there's one issue that is of great interest to me, which is that I think we need to continue to keep the structure of delegation and committees under review. There's quite a temptation often on boards to bring heavy paperwork with financial appraisals, critically important decisions, to the main board. I would far rather that we were able to find a way of ensuring that the analytical work was fully done, but then came to the board with a strong recommendation from a committee that had done it, so that we can continue to focus the board on the substantive issues around clinical quality, for example, the patient voice, and the vision of what we are doing for the future. And I think the value that the board can bring is greater in those areas than in the detailed financial appraisal. So this is not for today, but it's a thought about how we would handle board business for the future.
Yeah. I think that's a point very well made, Chair, and Paul and I have been talking about the possible remit of a investment and finance committee, which could do a lot of that hard slog. And I'm sure we'll be inviting members to express an interest at some point.
Many volunteers. Good. Thank you very much for taking that on board. Maybe move on then to item 7, which is pricing governance. Bill and Paul.
Thanks, Chairman. Do you want me to lead us? Thank you very much. Thank you very much, Chief Finance Officer. This is clearly related to the broader governance of the board. Just to remind the board, we shall have a joint responsibility with Monitor for setting the annual prices for hospital care in the national tariff. The proposals here are that we should discharge some of the jointness of that through a joint pricing executive, to which then we would delegate some of the day-to-day operational decisions of the sort you were talking about actually in some of the financial appraisals just now. The proposal, however, is that both Monitor's board and our board would retain the strategic decision-making power, particularly on long-term pricing strategy, on scope and structure of tariff, and that I think is particularly important. It's the sort of area of discussion which we need to relate to the vision of service we want to be able to provide for patients. So if we want an integrated experience of care for vulnerable people in the community, then we need to make sure the pricing structure that we're developing is supporting that. It goes hand in hand with the right sort of care and experience. And the third key decision we think the boards should each retain is around publishing the tariff itself each year. We've got good, close working arrangements, I think it's fair to say, with Monitor. They are taking this paper to their board as well, and we're making the same recommendations. And I think I can give the board assurance that some of those early concerns about two separate organisations being given a shared task, I think we've made huge strides in getting across those worries, and now we're effectively, for a lot of this, in acting as a single joint team, and I think that's got to be right for the interests of patients and the service. So I commend these recommendations to the board.
Thank you. Paul, anything to add? Nothing much to add. Okay. Are we happy to adopt the proposal to approve the proposed terms of reference for the joint pricing executive and to proceed along those lines? Thank you very much indeed.